in a minute.
Okay, yeah.
Yising, would you like to start?
Okay, right. Hi everyone, I hope you're keeping well. I'm Yising, the co-president of Cambridge University Biological Society, fondly known as BioSoc. Thank you very much for joining us for our inaugural talk, co-organized by the 2020/2021 committee and the Sensor CDT, which is the Center for Doctoral Training in Sensor Technologies at Cambridge. Joining us today on Zoom are Dr. Philip Mayer, the Program Manager and MRES Course Director from the Sensor CDT, as well as some of their students. From BioSoc, we have Christoph, Co-President, Shreyas, the Vice President, Mirta, the Secretary, Eliza, our Treasurer, Ellie, the Speakers Officer, Manon and Zien, our co-sponsorship officers. And last but not least, we are very grateful to have Dr. Olivier Restif as our speaker today. Dr. Restif is a lecturer and an epidemiologist here at Cambridge, working on zoonotic diseases. His work includes modeling viral pathogen circulation in fruit bat hosts, as well as studying how evolutionary biology and the study of ecological dynamics could play a role in controlling zoonotic pathogens. In his talk today, he will be highlighting different ways in which different types of models are used in response to COVID-19. He will also explain the general principles at the heart of epidemic theory and discuss some of the challenges facing modelers tackling the pandemic in real time. Just so you know, this session is live streamed on BioSoc's YouTube channel due to significant interest, and the recording will remain on the channel after the session. So we would be very, very grateful if you could subscribe to our channel to keep up with our future talks. This talk itself will last for about 45 minutes, followed by a Q&A session. Please post your questions and comments either on the Zoom chat or the YouTube live chat throughout the talk. Christoph and Philip will be moderating the Q&A session. So now, without further ado, I shall now pass the virtual floor to Dr. Restif. Thank you.
Well, thank you very much for the introduction, and good afternoon to everyone. Yeah, as a modeler working on bat diseases, I usually have a very quiet life, and once in a while there's a big epidemic, or in this case a big pandemic, and suddenly everyone is interested in mathematical models for infectious diseases. So I received these two invitations at the same time, so we have a fairly diverse audience this afternoon. So I've tried to have something for everyone. There will be some more general and some more technical elements, but hopefully we'll have time for questions on even the follow-up afterwards. So what I thought I would do this afternoon is to give you first an overview of how mathematicals have been used in the last few weeks in the context of this pandemic, and then go back to some of the general theory, general principles on how epidemic models are built and used, and then going back to a specific example, so using what we will have just learned on epidemic models, see one particular example that's been used in the last few weeks. So in many ways, this is a very unprecedented situation for all of us, but it's obviously not the first pandemic that has occurred. And this is just a diagram showing a selection of emerging zoonotic viruses. So by zoonotic, we mean viruses that have been transmitted from animals and quite often from wildlife to people. And this coronavirus is just one of many, many zoonotic viruses that have emerged and entered the human population, the human species, over the last few decades. And as you see, a few of them managed to cause pandemics. So this one is unprecedented in many ways, especially for because of his the speed at which it has spread. So living in lockdown, it's very easy to lose track of time, and it's quite sobering to remember that just 6 months ago, nobody had heard of this disease, and probably hardly anyone had caught the disease. And as far as we know, it really started spreading in China, in Wuhan in December. And it's only at the end of December, when enough cases had been recorded, and then that the medics in China realized that they were dealing with an outbreak, that they raised the alarm. And fairly quickly, they were able to identify a virus causing all those cases of severe pneumonia. And it made the news around the world, but unless you had an interest in coronavirus, you probably didn't pay much attention to it, or unless obviously you had family in Wuhan. And so not much happened as far as we could see, but what happened under the surface was that the virus was circulating and was infecting more and more people in China. And fairly rapidly, by the end of January, it became clear in China that they were dealing with a proper outbreak, so with this exponential increase in the number of cases. So just to explain what we have, I'm sure by now you're familiar with these types of graphs. So we're looking at a log scale axis here. So this is the number of confirmed cases, and more specifically, the cumulative number of confirmed cases in different locations. So with this axis going up in factors of 10. So where you have these straight lines going up here, it's really showing an exponential increase, which is the hallmark of an epidemic. And while we watched China having to deal with this outbreak and imposing this very strict lockdown in Wuhan, one by one, other countries started to detect their first cases of coronavirus. And then at various points during February and March, we started to see cases actually being transmitted within countries, what we call community transmission. And basically, epidemics started in almost every country in the world. So we reached that point where we had a proper pandemic, and we had this very fast rate of increase in many countries. And so just 2 months ago, mid-March, the UK imposed its own form of lockdown. And it's worth remembering that at that time, there were only 1,500 cases recorded in the UK. And now we are around 250,000 total cases confirmed in the UK. So at that time, basically everyone was trying to deal with those epidemics and imposing some very strict measures. These seem to have worked to some extent, as we have now reached a point where in most locations, most countries, we have a slowdown and a decrease in the number of cases. And now the big question is, how do we get out of this situation here? Because we know that as soon as we release restrictions, there's the potential for more cases to spread and new epidemic waves to occur. But it's also unprecedented by the amount of data that we can see and that everyone can see in real time. So this is just a screenshot of one of the many dashboards. On this one is one of the most publicized and the most reliable one, which was designed by researchers at the Johns Hopkins University in the US. And basically, if you go to their website or any other of those dashboards, you can click on point and you can interactively visualize the number of cases in space and time, the number of deaths. So it's that very weird situation where, from wherever you are in the world, you can see in real time what's going on anywhere else in the world and follow this pandemic day by day. And then in the news, you have all kinds of visualizations of all kinds of data. This one is showing the number of deaths, and I picked this one from the Financial Times. But you have effectively this avalanche of data that's trying to show us what's going on here. And then you have the temptation of trying to rank countries by how well or how badly they're doing. So is that a good thing or a bad thing to have all these data? And unfortunately, it's not necessarily very informative. So just having data is not sufficient to have knowledge. And quite often it's a case of more quantity than quality. And some of the limitations are that all those statistics or all those data are effectively just reporting the number of confirmed cases. And that means that we need to have some form of case definition. And unfortunately, that's not completely uniform across countries. And that has changed also with time. And typically that involves having some form of test of suspected patients being then tested for the presence of the virus. But what will have a big impact on the number of cases reported is not only what test is used, but also who gets tested. Is it only people with symptoms, only people presenting to hospitals? And we've heard a lot about those issues in the news. And there are also reporting delays. So even though it looks like we are visualizing data in real time, sometimes there are several days or even weeks of delays, depending on how fast all those samples can be tested and then the data collated. And then it's not just the number of cases, you have all kinds of other statistics that are reported, and that are also data, but from different sources. So you have total number of cases or cases just in people in intensive care units or just in hospitals, number of deaths. But now we are also starting to see not just the number of confirmed deaths caused by COVID-19, but also this this excess death. So compared to previous years, how many more deaths have occurred in the last few weeks. And then you can take some ratios. You can divide the number of deaths by the total number of people who are infected, or the total number of people who have symptoms, or the total number of population, total size of the population. So you end up with all these statistics, and it's very hard to know how to use them. And quite often they are misused, sometimes for political purposes. And in particular, when it comes to country comparisons, it's very tempting to say, well, you rank the countries by what looks like a very objective measure of number of cases. And it's very tempting then to attribute these rankings, these differences, to whatever factor you like. But it's important to remember that it's a very complex set of factors on differences just in the age pyramid, the age structure in different countries, the prevalence of comorbidities, so other conditions like obesity, like diabetes, that have a very strong impact on whether someone who catches the disease will then develop severe symptoms, on the amount of travel within and between countries, and then, of course, variations in behaviors and in policies. So with all that information that's very easy to, as I said, to misuse, then we have two classes of problems. One is, which are very classic problems in data analysis. So you have this iceberg problem. So what is the real size of the iceberg? By which I mean, what is the real number of cases of people infected in any place? And so we are comparing different tips of icebergs and trying to make a guess. And then the other issue is cherry picking. So we have all those different statistics, and it's very easy to just to choose any of them, either intentionally or not, and assume that we have a causation between two factors. So to help with this interpretation of data, to make sense of the data, we use models. And unsurprisingly, we also have a pandemic of models taking place. And what's quite unusual is that in the news, we hear a lot about those mathematical models. And it started quite early on. So this was from early February. As I said, that was a point where it was not quite a pandemic yet, and we just started to see imported cases in a few countries while China was dealing with very large outbreak. And there were already people, a few teams, trying to model these epidemics and forecasting what was going to happen. And then, as other countries like the UK started to battle these outbreaks, then we had the questions of what should we do about them, and there again, mathematical models were used to guide the implementation of control measures. And now what we're seeing as we are discussing the possible ways to get out of the lockdown, we're also seeing the use of models to predict what may happen if we open schools, for example, which is a big discussion at the moment, as you're very aware. Okay, so that was in the news, but if you look at the more traditional places where you would expect to see really all these models, which is in the scientific literature, do we get the same picture? So I think many of the biologists in the audience will be familiar with PubMed Central, which is a repository for publications, so all peer-reviewed publications in biology and medicine and life sciences in general are collated on this website. So this will tell you, this will give you the list of all publications that have those keywords. And just in the last 4 months, we've had 190 papers collated on PubMed that contain these keywords, COVID-19, mathematical models. So is that a lot? Is that not a lot? If we compare to what was published in the last 12 months for malaria mathematical models, we got 600 papers. So around 200 for COVID-19 the last 4 months. You see that's the same order of magnitude of papers published on malaria or on tuberculosis. On malaria and tuberculosis, I picked this because these are two of the big killers, two of the most important infectious diseases in the world. And tuberculosis still kills around 1.5 million people every year. So that's just the papers that have been published that have undergone peer review. And obviously, in the very short period of time that we've had, again, we're only seeing the tip of the iceberg of those mathematical models. So another place to look is repositories for those preprints. And anyone in the audience coming from physical sciences will be very familiar with preprints. It's a much more recent phenomenon in biology and especially in medical research. So this repository, this website, medRxiv, was actually set up fairly recently, and until recently was fairly quiet. And then it exploded literally with all those uploads. Anyone, basically, any researcher decided to write up some manuscript about COVID-19 and uploading it into medRxiv. So that was just from a few days ago. There were already almost 1,000 preprints about COVID-19 mathematical models. And I don't know if you can read some of the titles on the screen here, but you have all kinds of models, and a lot of it is rubbish, to be honest, and a lot of it is effectively noise on just people trying different ways to use models with not necessarily very good understanding of how to do it and how to make it useful. So we have this, again, it's avalanche of mathematical models, but in the midst of all that, there is a lot of very useful work being done. So to give you a few examples of how models have been used for COVID-19 in the last few weeks, and especially a lot of the examples I'm going to show here come from very experienced teams of epidemiological modelers, and most of them are actively involved in advising governments either in the UK or in other countries. So before looking at how models work and how you build the models, it's worth explaining how they are used, especially in the context of COVID-19, but these principles apply to any other diseases. So you can use the models to estimate the size of the iceberg. So given a number of cases that you can then stratify by age, by sex, by any other factors. You can then use this data to try to infer the total number of cases based on some epidemiological rules, which I will explain later. So this is an example from a study in France, from the Pasteur Institute. And what you have on the vertical axis, that's effectively the proportion of all cases, known or unknown, who had to be hospitalized. So in the overall populations, it's less than 5%. But as you know from all the reports in the news, there is a huge difference between age groups and also a difference between males and females. Another example is of application of models is to really understand how transmission working. So what is driving the spread of this pandemic? So it's about the mechanisms. And I will explain this particular example a bit more later, but what it's showing here is looking for mechanisms that could explain why we see so fewer cases in children than in elderly people. And one question is whether that's because children are less susceptible to infection, or whether they, if they get the disease, they are less likely to show symptoms. So we can use models to explore these different mechanisms. And what also quite often makes the headlines in the news is that you can use model for forecasting. But it's important to highlight that it's not really the primary function of models, especially in epidemiology, and it's still a bit of a dark art to make these forecasts. So this is an example from a study by Imperial College from several weeks ago now, what feels like a lifetime ago. But you can see based on the records of number of deaths in previous weeks, they project for a few days ahead what they expect to see. And then there are other ways to make predictions about not just what will happen, but what could happen in a parallel world, what is sometimes called counterfactual, but that's just a fancy word for a what-if scenario. So I'll explain again this a bit later if you're not familiar with this concept of R-naught, even though it's been in the news everywhere. But that's effectively on the x-axis a measure of contagion. So how many secondary cases are caused by each person on average. So the blob at the top in red is showing the estimates, so with a measure of uncertainty. But you can see the average here is about 2.5. And that's the estimate in the real world. And then we can ask, okay, so with our model, we can simulate what would happen or what would have happened if all the schools were closed, but nothing else was changed. Or if we impose social distancing only, or shielding of elderly people only. Or if we impose all of the measures above. So that's obviously very useful, not only to look at the past, but also as ways to look at what could happen in the future under different scenarios. So now that I've given this introduction, this kind of motivation of what models have been used for, let's look at what are models. So obviously model is a very generic term. And what all models have in common is that they are simplified representations of reality based on what we observe, on what we understand about reality. So it's really, first of all, a mental representation of the particular phenomenon, but very importantly, it's simplified. So it's not meant to capture all the complexity of life. Also, very importantly, these models are tools. And they are designed for specific purposes. That's why we have a lot of different models. There is not one size fits all. And then we, as models, we always like to quote statistician George Box, who said all models are wrong, but some are useful. And finding out what makes model useful is not always easy or straightforward. To give you an example, on really get this idea of the fact that a model doesn't have to be accurate to be useful, I don't know, again, if you can see on your screens very, very clearly, but hopefully you can guess, even if you can't read, that we have on the screen here 3 maps of London, the tube map, a map of land use, and a map of cycle route. And so if I asked you which of these maps is the most accurate, you would probably pick the one in the middle. But if I ask you which one is the most useful map of London, if you had to take one with you to go to a trip to London, then obviously your answer would depend on whether you're planning to take the tube or planning to go on a bicycle. And obviously, in the current context, I'm sure you will all take the bicycle. So then what kinds of models do we have? They're all, as I said, very, very diverse, and they depend on their structure, the assumptions that they rely on how they are linked to data, on how the different variables in the model are related to each other. The types of models that we use in epidemiology are specifically dynamic models. So they are really meant to represent processes through time. And typically, in scientific context, these are partially observed processes. And that's why we need to make models, because we don't have access to all the information. And as I'll explain, then you can have different approaches. You can have empirical or mechanistic model. You can have deterministic or stochastic models. So to illustrate this concept of empirical versus mechanistic models in dynamics, let's assume that we are following the motion of a ball that's been thrown into the air, and we record at a few time points the position, so just the elevation of the ball here. So that's your data. Okay, and then we're going to use a model to connect the dots and try to figure out what happened. So this is an example of fitting effectively a line between these points. And obviously not all points are on the line, and they shouldn't all be on the line, because there's always some element of error or uncertainty. So we need to take that uncertainty into account. And this can be achieved with two different approaches. One is an empirical or statistical one. So when we have 2 variables, elevation and time, and all we want is some mathematical representation of the relation between these 2. So all we need is to find an equation that gives the best match. In other words, that minimize the error between the two variables. So just looking at the data, you can choose to use a polynomial function. You could use any other mathematical expression. In contrast, mechanistic approach will start with what we think may be causing the relation between these 2 variables. So it's about the mechanism that we think is underlying the phenomenon that we observe. And in this case, we're going to use Newton's law to write a differential equation that describes the change in elevation as a result of the action of a force, in this case gravity. So this is the model, and obviously it's not directly the representation of z against time. To get to that, we need to solve the differential equation, and we can get an expression. And it's very similar to the one I put on the left. So it's also a polynomial, a quadratic function of time. But in this model here, one difference is that the parameters, z0, v0, and g, which are constant, have a physical meaning. So they represent physical quantities, either constant or quantities that represent the initial conditions of the experiment. Those parameters in both cases may be known or unknown. And if they are not known, well, then we can use this exercise of fitting the model to data to estimate the parameters. And we can do that whether we're dealing with an empirical or with a mechanistic model. Okay, so that's a fairly classical example that I think most people will be familiar with from school. But effectively, we're doing the same. We do the same with epidemic models. So we've been doing actually this type of work for over 100 years. And this is one of the early examples, a paper by Kermack and McKendrick, who were epidemiologists. And they took in this example data of a plague outbreak in India and look for ways to represent mathematically this epidemic curve. So we're going to build mechanistic models. So these models are made of a few different things. So they have dynamic variables that represent things that we can measure, or things that maybe we would like to measure, like the number of cases, number of deaths. Some of them may be unobserved. And the model itself will describe the processes that result in changes in this number of cases, like infection, death, recovery. And they use parameters to quantify the rates at which these events are taking place. So what do we need to build a model for an epidemic? So there are a few basic principles that we can use. And quite often we will start from a kind of clinical or epidemiological point of view of people, or it could be animals, that undergo a disease. So at any time, anyone can be either infected or not infected. Either you have it or you don't have it. But then to result in transmission, we need some form of contact between someone who's infected and someone who's not infected. But we have to be more specific, because just the fact that you're infected doesn't mean that you are necessarily infectious. You could also have a latent infection, and in that case, you won't be able to transmit the disease. Likewise, if you're not infected, doesn't mean that you will catch the disease every time you meet someone with the disease, because it could be that you are actually immune to this disease. So we end up with this classification of individuals being in either of these any of these four states at any time. This is just the starting point. We could have more complex and more kind of intermediate states, but that's really all we need to get started. We're going to use these abbreviations to follow these states. And what the model will do is describe how individuals go through these states, so how they change or move from one state to another. We can use a diagram like this that represents the cycle of infection of a typical disease, where upon exposure, individuals will start with a latent infection and then move on to being infectious and then recovering. But other diseases may have other cycles. The next step is to translate this model, so this diagram, into something a bit more formal that can have then a mathematical expression. And then again, there are two main different approaches to do that. You can look at this diagram and say, okay, so that's the state of an individual. And what you can do is model individuals in an individual-based model or agent-based model, where any person is in a given state and go through them. But what we're going to look at here is actually a different approach, where we look at it at the population level. And what these variables S, L, I, R will represent are the numbers of individuals in each state at any time. So we have a total population, which is split into 4 compartments, and the model keeps track of individuals the number of individuals going from one state to another. So we're not keeping track of the individuals themselves, just a tally of how many people are in each state at any time. So to look at that in a bit more detail, to build the model itself, we're just going to have a slightly simplified model, which is the most common one, which is used at least for teaching purposes, which is the SIR model. Individuals can be either susceptible, infectious, or recovered on immune. So we have 3 variables representing the number of individuals in each state at any time, and 2 processes. The first one is transmission, that takes individuals from S to I, and recovery, that takes individuals from I to R. What's important to realize that there's a major difference between these 2 processes. Transmission is effectively occurring at the population level, where it involves some interaction between individuals. So the rate at which susceptible individuals become infected is not a constant. It will depend on how many other infectious individuals there are in the population. And there is also an individual level process depending on how susceptible you are to infection, and also how contagious the virus itself is. Whereas recovery is an individual level process. And here I've just put 2 equations, or 2 mathematical expressions showing the rate. So what I mean here is that we're going to assume to build a mathematical model, assuming that the number of new infections per unit of time can be is equal to this product of the number of susceptible and the number of infected individuals, and a constant beta, which is this transmission rate. So this is just one particular model, one way of representing, of assuming that the number of new cases is proportional to the product of S by I. Whereas the number of recoveries, so the number of individuals who move from I to R per unit of time, will be just gamma times I. So gamma is the recovery rate, and that's just a constant for any individual. So now we have a complete model that we can turn into equations. For example, if we want to use a deterministic model, we can write differential equations. We could use these rates as probability distributions to get a stochastic model, which I'm not going to talk about today. So if you're familiar with differential equations, this is what we have. So we have three equations. Each of them on the left-hand side, you have something that represents the change in the number of individuals in each category. On the right-hand side, you can just recognize the terms of these two rates. So this is the definition of your model. So to be able to use it, then what you need is, first of all, to have the values of the parameters. And quickly, I'm going to mention how these, in this case, these parameters can be estimated from data using some properties of this model. So the easy one is the recovery rate. There's a mathematical property of these models, which is that in this case, if gamma is the recovery rate, 1 over gamma will represent the average infectious period or the average duration of infection. And this is something that can be measured clinically. If you follow individuals, you may have data that tell you how long individuals are infectious for on average. Measuring the other parameter, the transmission rate beta, is much harder because typically you can never follow and observe all the transmission events occurring. So we have to use indirect measures. And one approach, if you're observing at the early stages of an epidemic, where effectively the epidemic is growing exponentially, you can get this exponential growth from one of the equations here, assuming that we have a large population, that effectively the number of susceptible individuals, S, remains constant. And from this exponential growth, you get a function of the parameters beta and gamma. And if you have the data that tell you how fast the epidemic is growing, you can equate the doubling time of the epidemic in your data with this quantity here. That gives you the values of beta and gamma. So if you already know gamma from clinical data, you can then infer the value of the transmission rate. So that's really the simplest case, but other applications are effectively just trying to apply these principles in slightly more complex cases. Brief mention for the basic reproductive ratio, basic reproductive number R naught, which I'm sure everyone has heard of, but if you haven't come across the actual definition, so it's the average number of secondary cases caused by a single individual in a fully susceptible population. On the second part of the definition is very important. It's really defined in a fully susceptible population. And in other words, it really applies only to the start, the first few events of transmission in the population. And that's why it's called basic, and that's why there is this note in R naught that's representing the first generation of transmission. A few important properties. The first one is that it's called a ratio because it's not a rate per unit of time. We already measure or we quantify the number of secondary cases for as long as this index case is infectious. So until the index case either recovers or dies. So it doesn't give you a direct measure of the speed at which the epidemic will unfold, but it will tell you whether it will either grow or spread or not spread. And as you can guess from the definition of R naught, if each person only gives rise on average to less than one more new case, then the epidemic will die out. But if R naught is greater than 1, then the epidemic will spread. So we have this definition here, which is independent of the model chosen. So we can use this definition on the properties listed here with any model, any disease. So it's really a universal currency for all epidemics. If you have a particular model, like the SIR model, you can use the mathematical definition of the model to come up with an expression for R naught. In this case, it will be beta n over gamma, where beta is the transmission rate, gamma is the recovery rate, and n is the population size. And that comes from the fact that we have the model that describes the number of new infections per unit of time. So that's the rate, number of new infections per unit of time. And we multiply this rate by the average duration of infection. And the product will give you R naught. The dynamics will look something like this. If you solve numerically the model for particular parameter values, you have the epidemic curve that you can see in red. And blue, S is the number of susceptible, and R the number of immune individuals. A few things to highlight. The epidemic peak occurs at some point where we reach the maximum number of cases at any given time. And the reason why there is a peak and then the epidemic dies off in any case, even if we start with R naught greater than 1, is that basically we run out of susceptibles. And mathematically, you can work out that the position of the maximum occurs when the derivative of R is equal to naught. And from the differential equation, you can work out that this occurs when S, the number of susceptible individuals, gets below a threshold. So if R naught is 3, then as soon as you reach less than a third of the population, the total population being left susceptible, there won't be enough susceptible in the population to sustain the epidemic, and the number of cases will die out. And at the end, not everyone will have got infected. Even though everyone in this model was assumed to be susceptible, not everyone will get infected. And we can measure the epidemic size by looking at the end of the epidemic, how many people got infected. And I just wanted also to highlight this term of herd immunity. That's this idea that there is some protection conferred by the fact that some people have become immune. And we can see the decline of the epidemic before everyone gets infected. And this occurs where, again, the proportion of susceptible is less than a third. Okay, so in the last 5 minutes, I'm just going to show you a model in action for COVID-19. So I picked one particular model out of the many that have been published. This one came from the London School of Hygiene and Tropical Medicine. And they developed this model for the purpose of asking why are there so few cases of clinical cases of COVID-19 occurring in children. As I mentioned earlier, there are two main hypotheses. One is that children are less susceptible to infection, so they are less likely to catch the disease. And the other one is that they are more likely to be asymptomatic or subclinical. So that's the severity hypothesis. In order to find out which of these hypotheses is correct, we would need direct evidence. We would need to have large-scale testing of the population, and especially children. And that's typically not possible, at least in the short term. So we're going to use a model, or these authors use the model to try to test these two hypotheses. So this is the model they used, and it looks a bit complicated, but essentially it's an SEIR model. So it's a compartmental model where individuals can be either susceptible, latently infected, infectious, and recovered. But this simple SEIR model that I described earlier lacks two important factors. One is the fact that it doesn't say anything about symptoms. It just says whether individuals are infectious or not infectious. So we need to add symptoms. So you have these actually three subtypes of infectious individual. And there are two routes of infection. You can either go and become clinically infected, so develop severe symptoms, or some individuals with a certain probability will develop subclinical or asymptomatic disease. And then the other factor that you need for this study is age groups or age. So there are different ways, more or less complicated, to include age, but in this case, they just assumed, they just split the population. So effectively split each of these compartments into sub-compartments based on age groups in bins of 10 years of age. So the variables depend on the age, so that they are stratified by age, but some of the parameters are also assumed to be dependent on the age. And in particular, we allow both the infection rate or the susceptibility to be age dependent on the severity. So the probability with which you develop either a clinical or severe disease or a subclinical disease. So what they did then was to fit these models to data, and they had epidemic curves from different locations. And then at the bottom, you can see you also have the stratification of the incidence, so the number of cases per age group. And then they took their models and looked for parameter values that gave the best match to the data. And the short answer is that the best supported model is a model in which it's the susceptibility that is dependent on the age rather than the severity. Once you have this calibrated model, you can then use it to predict what would happen under different scenarios. For example, what would happen if we had a COVID-19 epidemic occurring either with schools being opened or schools being closed. And what you can see on some of these graphs here, that actually there was not, according to the model, there's not a huge difference between, or a huge effect of having schools closed during the outbreak. But obviously, even what may look like small differences could have a big impact in reality. But what was quite striking was that the small difference was completely different from what would be expected if the outbreak was caused by influenza. So from influenza models, we expect a lot of transmission to occur in schools, and therefore we expect a huge difference between the scenarios with open schools or closed schools with influenza. So this was a bit of a surprise, and this is at the this really explains why there is so much controversy at the moment about whether we should reopen schools and whether that will have a substantial impact on the resurgence of the disease. So that's all I wanted to tell you. So just to conclude, I've shown you that models are used in general in the context of epidemics, but here specifically in the context of this pandemic at different stages to fill in the gaps in the data and ask some of these questions about the true scale, on the spread of the pandemic, on what could be the effect of different control measures. So I've shown you that we can use what we call compartmental models, and that's one of the main types of models, but by no means the only one that are used to solve these problems. But what's important to remember is that we don't need to know all the parameter values, and we don't need to know which is the correct set of assumptions. We can learn that from the data by fitting models to data. Okay, so I'll stop here, and I'll be happy to take any questions.
So thank you, Olivier, for that very informative talk. Does anyone on the Zoom chat have questions? And do please submit your questions if you're watching us. If you're watching the talk via YouTube, do submit your questions to the group chat, to the chat that we passed on to us. I believe that Philip may have some questions.
Hi, Olivier, thank you very much for this talk. It certainly enlightened my understanding of the models that are being used. So the R0 has been talked about quite a lot, but what you're saying, it's a basic property of, say, a given disease that doesn't really change. So what are people talking about with R0 getting smaller or larger than 1 now?
Okay, so what I defined, what I showed you in this presentation was our note on that. The note, the 0 here, as I said, was really is really showing what happens at the start of an epidemic. But it represents the average number of secondary cases caused by a given infected individual. So you can also measure or estimate this reproductive ratio at any stage, any point further down in the epidemic. And because of either the increase in immunity, so the fact that there are fewer susceptible individuals around, or because just of changes in the behaviors or changes in the interventions, you can expect as the epidemic unfolds that each infected individuals will tend to be able to transmit. So that's what is measured, this R number, which more formally is usually known as the effective reproductive ratio, RE, or sometimes also written as RT, where T represents the time, to represent that it becomes a variable that evolves through time. But it still has this fundamental property that if it's below 1, means that you expect the epidemics to wane, because each individual will not be able to infect more than one individual before they recover or are isolated.
Do we have any questions from the audience? Otherwise, I do have a few more.
I have one. I was just wondering if you're able to explain the weekend effect. Why are we seeing less reported deaths from the weekend? As in, I would have expected, I know that's true generally for deaths across any medical reason, but for the coronavirus, I'm not sure why.
To be honest, I don't know. There's one issue that I'm aware of that's also very general, which is about the reporting. And you get more cases that actually just the physical process of reporting a case, detecting and reporting a case, is more likely to occur when the people tasked with reporting it are at work. Whereas at the weekend you have just fewer people working, and the work doesn't get done usually, and therefore the cases will just have to wait until Monday. So even though the transmission may be taking place at the weekend, they may only be reported in the logbook when the epidemiologist comes back to work on Monday.
Thank you.
So we also have a question from the YouTube audience. I quote, "You wrote that if R0 is greater than 1, the epidemic can spread, not that it will spread. In what scenario would it not spread?"
Okay, so that's something that indeed I wrote for a purpose, but I didn't expand on it, so very well spotted. So what I showed you, the example of model I showed you was a deterministic model with a set of differential equations. So for a set of parameters, given initial conditions, it will always behave in the same way. And if R0 is greater than 1, it will spread. You will have an outbreak. In reality, life is random. And if you use a stochastic model, you'll be able to capture some of the variability. So even for a set of parameters, you will have just random processes. And remember, in order for the outbreak to grow, to spread, you need to have at least, well, more than one case, so at least 2 cases of transmission before the index case recovers. So in reality, when the index case recovers is a stochastic process. So it could be that just by chance, in this particular occasion, individual recovers or dies or gets hit by a bus just before this individual was able to transmit it to other people. So in a stochastic process, you will see, even if R0 is greater than 1, you will see a lot of failed outbreaks that just by chance don't have enough transmissions, and that typically at the start, in the early stages, you can have these failed outbreaks, but on average, they will take off, but the variance can be huge.
Thank you. And we have another question from the live audience. Would you be able to explain the concept of force of infection and how that is modeled?
Okay, so the force of infection is linked to the transmission rate, but it's just it's a different denominator. So it's representing the number of new infections per susceptible individual. So it represents, if you are susceptible, how fast will you be infected. Whereas the transmission rate, the parameter beta that are represented, was normalized by susceptible and infectious individual. So we can measure or report different rates, again, with different denominators, and the force of infection is from the point of view of a susceptible individual. And therefore, the force of infection is a function of how many infectious individuals are around you.
Thank you. And we also have thanks from the person who asked the R naught is greater than 1 question. That's been well explained. So thank you for that. Another general question. Oh, actually, we have a question from our co-president. Would you mind elaborating on the terms preclinical, clinical, and subclinical as used in this context?
So in this context, so clinical means someone who will show symptoms that will be effectively that will require some form of either hospitalization or that will be recognized as symptoms. So to be honest, I don't know the exact subtleties between, there will be a difference between asymptomatic and subclinical. Asymptomatic would be strictly someone who doesn't show any symptoms, and there's a suggestion that actually it's very, very rare. What's more likely to occur is that you may show some mild symptoms that will not be recognized clinically as being symptoms of COVID-19. So that's the branch of basically people who get under the radar of those kind of subclinical or asymptomatic or undetected cases, that you would only be able to identify if you tested those people, for example, in the case of contact tracing, if they have been in contact with a known case of COVID-19. And then the other branch are subclinical, sorry, the other branch is preclinical followed by clinical. So the preclinical stage would be people who are infectious but do not yet show clinical symptoms. And then the clinical stage is where you show the symptoms. And so just based on your symptoms, you're more likely to be isolated, either to self-isolate or to be hospitalized and therefore become isolated. So you have this crucial period of people who are in this preclinical stage who are able to infect other people, but without knowing it.
And another question from the live stream, taking only epidemiology and public health into account, that is not considering economic arguments, what would you advise headmasters currently considering whether to reopen their schools do at this time? So I will not give any advice online because that would be unwise. But as I said, there are elements there are lines of evidence. Unfortunately, many of them are indirect, as I've showed you in that particular study, that indicate that not only are children less likely to be reported, but it looks like they are actually less likely to be infected. As far as I know, there are no known outbreaks of COVID-19 in schools, even before schools were shut, or when, in some countries like Sweden, who have not closed their primary schools at all. So there's fairly good confidence that even if some children occasionally get the disease,
it's unlikely to cause a large outbreak, in contrast to what we often see with various diseases like influenza or measles or other diseases that can spread really like wildfire in school. So we don't expect that would be the case, but obviously that doesn't mean that it's safe to do it necessarily, and there are concerns about transmission between children and adults. And even though at the population level, at the national level, you may say, well, we don't expect to see a lot of cases. At the individual level, if you have people who are at risk, who are vulnerable, who are likely to, even if they are children or adults, they are more likely to get severe disease, then you have to consider that very carefully. So it's not just about numbers on rates, it's really about, it's effectively about risk assessment of what you consider as acceptable risk or not.
Thank you. And we have another question from the live video. How would you include spatial data and factors when modeling transmission, for example, for COVID-19? And that's something that I've been wondering myself, so I'll just latch on my personal question onto that as well. Is agent-based modeling feasible when considering COVID-19?
So there are different ways to add space to these models. There is obviously a huge literature on spatial epidemic models. So you can start with the compartmental models, and just as I showed you in the case of ages, where you can have multiple layers of ages, you can also have multiple layers of space, of locations. So you can model your populations, and for many diseases, it makes sense to assume that, say, in a city, in a town, you have a fairly well-mixed population. So you can have one unit, which is your homogeneous population in a town, and then you connect it in a network, a spatial network, you connect different populations. So that's an approach. You can have much more gradual approach with a continuous space to look at the spread, like a diffusion process of an epidemic. And then you have those agent-based models, and there have been attempts, and there are attempts to do that for COVID-19 and others. These can get quite complicated and therefore very very time-consuming, even with modern computing facilities on high-performance clusters. It can still be a huge task to run those models, especially if you do that for the purpose of estimating parameters, where you may need to run huge number of simulations.
Thank you very much. And we have another question. Is it possible to slow down the pandemic too much? If hospitals do not run at full capacities because policies have slowed down the spread, should the spread be aided to achieve herd immunity? So quite a hot topic there.
So I don't think it's fair to say that we should necessarily run at full capacity. And again, there's a distinction between the kind of cold numerical or quantitative approach to say, how many cases can we afford to have, and how soon can we reach herd immunity, or how soon can we get to the point where we have a vaccine that's available. And these are, there are different considerations about what should be done, and there are different levels of cost as well. There's obviously the human cost, and not having hospitals running at full capacity means that actually you have the capacity to treat patients with cancer or who would otherwise die of cancer because they can't get their treatment. So there are all those indirect costs of dealing with the pandemic and not being able to deal with other problems in society. So all that has to be taken into account, and reaching herd immunity is not a goal in itself. It's a stage where we know that we would see a slowdown of infections, but that would be at the cost of huge number of deaths, because say with an R naught of say 2.5, we would need to reach the point where 40% of the population has been infected, and then you can do the math to see how many deaths that, not only how many deaths, but how many, with the amount of morbidity on people have been put in hospital, in intensive care units, and then possibly dying of other associated causes. So that's why you have to be very careful on a lot of the very simplistic arguments in the media actually miss a lot of the considerations that are being really looked at very closely by all the bodies that advise the governments. There is really this trade-off between epidemiology and economy, and the economy.
Thank you. Another question from the live stream. When reading articles in epidemiological literature, how can you identify models that haven't been built well, for example, with poor assumptions or parameters used?
Well, that's, so obviously a lot of it comes with experience and expertise, but it's, I think the driving principle has to be that the model has to be fit for purpose. So the question is, what are you aiming to do with this model? What is the purpose of building this model? And then you can compare with either other models that have been developed for COVID-19, or just from the literature and the expertise. As I said, we have 100 years of experience in this discipline, so there is a lot of theoretical literature, and also a lot of practical examples where we know what works, what doesn't work, we know which assumptions matter in different circumstances. And a lot of these simplifying assumptions can do a very good job in some circumstances, and then they start to break down at others. And that's where expertise comes into account, is knowing where specific assumptions break down and need to be improved.
A question from the Zoom chat. In the graphs for the difference between influenza and COVID-19, the greatest difference seemed to be in time rather than the peak height between different treatments. So does the paper therefore base their advice on flattening the curve rather than how many people in total get infected? And a related question, why was the effect of school closures smaller in Zimbabwe compared to the European examples in either case?
Okay, so the last one, one of the reasons why they picked specific countries in that example was because of different age pyramids in those countries. And also available data, which I didn't explain, on contact rates between different age groups. And when you have an age structured model, what adds a lot of complexity to the model is that you have then to consider not just transmission in the population, but transmission between each pair of age groups. And it means that if you have 10 age groups, you have potentially 100 parameters of transmission rates, depending on what's the probability that a 5-year-old will infect a 25-year-old, or 25-year-old will infect a 5-year-old. So you have all these parameters. So you have a huge issue with dimension in these models. But there are data in some countries about just the rate of contact between different age groups, and that's what they used in this particular paper to compare what was happening. So the underlying age structure was one of the drivers, the differences between countries. When comparing the two diseases, influenza and COVID-19, so again, there was the purpose of the paper was not to give advice, but just to see what would be the effect of closing schools. But closing schools as a quantifiable, just an exercise, an academic exercise, and effectively you take the contact matrix of all individuals, of all age groups, And in the data from the surveys of contact groups, we know which proportion of contacts occur at school. So we know that a proportion of contact between 5 years old and 6 years old, or 5 years old and 20 years old, occurring either at school or at home. And what they did in the model was to take these parameters, these contact rates, and effectively remove the contact rates that are known to occur at school and look at the impact of this. So this will have direct effect on transmission occurring within schools, and then this will have indirect impact on further transmission onwards. And in both cases with influenza or COVID-19, you don't see a major reduction in the total size of the outbreak, but it's more about the timing, as you said. And that's effectively just an effect of slowing down, because with influenza, as I said, you have these very large, very rapid outbreaks occurring within schools, and that kickstart the epidemic, and you can have a big impact on slowing down the epidemic by preventing these contacts between children in schools. Whereas with COVID-19, they only represent a very, they appear to only represent a small amount of transmission events, and that's why there's only a limited impact. It does slow it down a bit, it does reduce the total size a bit, but it's quite different from influenza.
Thank you. We've had a few more questions from the live stream and from the Zoom chat. First of all, from the Zoom chat, are there any models describing the probability of transmission from person to person? For example, modeling a spread between individuals in the building who come into contact for a certain amount of time and within a certain distance of each other. So I assume that's agent-based modeling, but within buildings.
Yeah, so these models, obviously, the thing that you can model anything. The challenge then is how do you calibrate or parameterize your model? So that's really dependent on having access to data, either the direct estimates of the parameters, the rate of transmission, or if you have, for example, a specific outbreak occurring in a given location, and there have been several examples in the past, independently of COVID-19, of hospital outbreaks or outbreaks occurring in schools or in other places where actual individuals and the timing of infection of individuals was fairly well recorded. And from these types of what we could call a kind of natural experiment, so these types of outbreaks, you can then calibrate this fine scale individual-based model. But as I said earlier, just like with the age groups, there have been a number of surveys measuring contacts, physical contacts, using physical distance between individuals, using tracking devices like Bluetooth or other devices. So we have these data sets that tell us about how individuals move around and how close they get to each other, and we can use that as a proxy for the risk of transmission.
Thank you. And another question from the group chat. What's the biggest bottleneck to network-based epidemic models, whether it's too many nodes or simulating the dynamics between them?
Sorry, did you say in network?
Yeah, in network-based epidemic models.
So in network models, it can be the number of nodes, but quite often there will be different levels of complexity in those models. Usually, if it's a static network where the structure of the network is set from the start, quite often in epidemic models we have very sparse networks. So we don't have usually a huge impact of the number of connections in the networks. So that may not be the main issue. What is one of the challenges at the moment is to model dynamic networks where the structure of the networks changes through time, or really in real time with the epidemic. And that's something that's obviously also quite difficult to do in a realistic way, and also challenge computationally.
So we have a few more questions from the live stream. Have excess deaths ever been used for other pandemics as a metric for other pandemics? And if yes, how useful are they in your opinion? And for how long do we expect excess deaths after the pandemic due to mistreatments, for example?
So excess deaths are a bit tricky, and so it's something that's really come to the surface fairly recently, especially in the UK, with data from the Office for National Statistics that is able to publish these data on excess deaths. And so big question at the moment is, what has caused those excess deaths, and what proportion of them have been caused by COVID-19 or by other diseases. We've heard about those cases of people who had underlying conditions, on just because being in lockdown or not being able to have rapid access to medical care, end up dying of what would be otherwise a treatable condition. So there are lots of additional reasons why people may be dying of in excess to what occurred in previous years. So there are a lot of statistical analysis, which is, I'm not aware of exactly what approaches are being used, but I think that tends to often to be more the realm of like public health epidemiology, not necessarily looking at not necessarily simulating the spread of diseases, but analyzing these types of data, looking at risk factors to try to infer what is the burden of different diseases in different conditions. So I think it's usually a slightly different approach, but there would be scope to use epidemic models to try to infer what proportion of these have been caused by COVID-19.
So I think we'll just wrap up with two more questions, one from the audience. Is there a model that could tell us the rate of infection in those that have been in isolation and never been infected when no longer self-isolating?
Again, it's something that you can put in a model. The challenge will be to have data that can measure that. So knowing what proportion of people came out of isolation, and we're hopeful that having more people being tested, and also the availability of antibody tests to tell us what proportion of the population has been exposed to the disease, will help to really refine some of these models and assess who is contributing or who has contributed to transmission.
Thank you. And a final question, perhaps steering away from epidemiology and the subject of this talk itself, but focusing more on your research with zoonotic viruses. What is currently known about the zoonotic origin of COVID-19?
So obviously there's been a lot of speculation. Unfortunately, a lot of those speculations have been driven by kind of political motives rather than scientific ones. But from all the evidence that we have, so first of all, we don't know for sure how the virus first spread from animals to people. We are fairly confident that the virus originated in bats, and that's because from past work of surveying viruses, in particular coronaviruses in bats, we know that there are lots of closely related coronaviruses that circulate in a number of bat species, and that's the closest match that we have. But the route of transmission itself could have occurred in various ways. usually bats excrete the coronavirus in their feces, and a lot of diseases are transmitted just by contamination of water or food from the urine or the feces of the bat. So that doesn't require physical contact. There are cases of disease that are transmitted when people eat wild meat. With these particular bats, I'm not sure how likely that would be, but there's been a lot of speculation also about intermediate host species. So the virus being transmitted again from a bat to another animal, like a pangolin or another animal that may be susceptible to the virus, and then this animal coming into contact with a human being, either again directly or indirectly, meat consumption or other sources. So it will be very difficult to get to the bottom of this one, but you know, it's at this point it's not a hugely important question. You know, we already know what are the risk factors for zoonotic transmission, so knowing where this particular one came from is not going to make a huge difference in our ability to prevent or at least reduce the risk of future pandemics.
Olivier, would you be happy to take one more question from the audience? We've just had one come in.
Yeah, sure, go ahead.
How likely, well, ending on a very optimistic note, how likely do you think is the bad scenario? That is no effective vaccine ever, no long-term immunity, no effective antiviral treatment, and annual mutations. And what could we do in such a scenario?
Run, or hide, rather. But yeah, more seriously, you know, a lot of these questions require different areas of expertise. But you know, I think the likelihood of all of these failing is quite low. In part because there's a huge effort in developing vaccines. There are still some questions about, you know, what will be the actual efficacy of those vaccines, on how lasting is the immunity. But I think it's very likely that there will be vaccines available that have some efficacy, and that therefore will be able to contribute to the response and to the control of COVID-19. It's in any case, what's very likely is that the virus will stay with us for a very long time. It would probably take a huge effort of vaccination around the world to eradicate this virus. At the moment, it's not looking very feasible, and it may not be necessary to do it, as what we expect is that at least over a few seasons or a few years, there will be enough buildup of immunity that hopefully can be managed, hopefully with the help of vaccines, to get to a point where it's more like influenza, where there is still some morbidity, there are still deaths occurring, but it can be managed, and we can at some point resume more normal lives. So that's it's a question of time, but I think it's very unlikely that everything will fail.
So Olivier, thank you so much for joining us, for giving a very informative talk, answering a lot of questions. We've been here for what, almost an hour and a half now. So I'd also like to thank everyone on the Zoom chat for joining us, to the Census CDT team for co-hosting the talk. We've had a lot of thanks on the YouTube live stream for a very interesting presentation from people who have asked questions, for helpful explanations. So as I can see, everyone very much appreciated this topical, relevant, as well as interesting talk. I'd like to thank once again everyone for joining us, my BioSoc team, our co-president Yising for introducing the talk. And if you'd like to stay updated on any future talks, do subscribe to our channel, follow us on social media. We will have another live BioSoc talk at some point in mid-June. The exact date and time is yet to be arranged with the speaker. But now, I suppose all that's left to say is thank you so much and goodbye, everyone.
Thank you. Goodbye and good luck, everyone. Stay safe and don't hesitate to get in touch if you have other questions or comments.
And of course, you can follow Olivier on Twitter as well.